Hello, I'm Maria Perez, and this presentation is about bulimia for N652. Bulimia is part of the eating disorders that can also include anorexia nervosa and binge eating disorders. These are actually serious illnesses that need to be recognized and treated. There's a misconception that eating disorders are a lifestyle choice, and that is incorrect. The complications of eating disorders are life-threatening and can have some physical and psychological complications. What is bulimia? It is binge eating followed by compensatory behavior. That includes the following. This behavior occurs once per week for 3 months. Binge eating is defined as eating a large amount of food in a short period of time in a sense of loss of control. That compensatory behavior to fix that includes self-induced vomiting, misuse of laxatives or diuretics, fasting, and excessive exercise. There is also a self-perception of being too fat. Bulimia nervosa can be further subclassified into the purging type and the non-purging type. The mean onset of this condition is at 12.5 years of age. It is more common in females, although males can also be affected. There's this intense fear of gaining weight in this patient population. Clinical findings include intolerance of cold, weakness, fatigue, presyncope, syncope, and unexplained change in the growth curve. Other findings include oral trauma, dental erosion to the teeth on the tongue side, perimollysis, which are dental caries on the lingual surface of the teeth, and swollen parotid glands. This does resolve with the cessation of purging. Cardiorespiratory findings includes chest pain, bradycardia, heart palpitations, hypotension, dyspnea, and edema. Bradycardia, if the heart rate is less than 50 beats per minute, it requires hospitalization. Some contributing factors to hypotension can include hypovolemia, malnutrition, and cardiac muscle atrophy. The dyspnea and edema signs can coincide with heart failure, as that can develop due to chronic malnutrition, atrophy of cardiac muscle, or electrolyte disturbance. GI findings are epigastric pain, abdominal bloating, heartburn, hematemesis, and constipation. The acid reflux can result from repeated self-induced vomiting and exposure of stomach acid to the esophagus. The repeated episodes of vomiting can actually lead to a Mallory-Weiss tear or Borjev syndrome in a worst-case scenario. Endocrine findings are amenorrhea and oligomenorrhea in females and low testosterone levels in males. Osteoporosis is another finding. Dermatologically, lanugal hair, like on the spinal area, hair loss. Russell signs is huge. Those are calluses or scars on the back of the hand and knuckles due to repeated induced vomiting. There can also be poor wound healing due to malnutrition. Other findings include the depression, anxiety, obsessive compulsive disorder, poor concentration, insomnia, self-harm, suicidal ideation, and seizures. Common electrolyte disturbances include hypokalemia and hypomagnesemia. Some acid-base disturbances that are also common is metabolic alkalosis due to excessive vomiting. The pathophysiology is unknown, although there are some risk factors as mentioned here. There's a screening tool one can use. It's called the SCOFF questionnaire, and an answer of 2 or more of yes can flag anorexia and bulimia. Treatment and management includes it's completely dependent on the presentation. If the patient looks toxic, the patient needs to go to the emergency department for evaluation and treatment. However, again, it depends on the presentation, so it is a multidisciplinary team approach that one takes, and if one's doing outpatient, it will include a PCP, dietitian, and a mental health provider. The treatment of choice is cognitive behavioral therapy, and that's with the focus on family therapy, and that consists of 18 to 20 sessions in a span of 6 months. So this is to allow the caregivers to support and encourage recovery by using a collaborative approach. Now, if this is ineffective, then individual eating disorder focused cognitive behavioral therapy should be considered. And this is per the National Institute for Health and Care Excellence. Medication as monotherapy for the treatment of bulimia is discouraged. Some antidepressants can be helpful, but there is not enough information on the efficacy of the treatments currently available due to the short duration of the studies from one of my findings. These are some labs that should be considered. And if some of these findings are present, depending on your location, in an urgent care, then you can put an IV in and treat the dehydration and assess and correct electrolyte abnormalities, do an EKG. In an outpatient basis, that picture can look different. These are conditions of when to admit either in the hospital or immediate psych. Some of the major red flags is suicidal ideation. A patient scenario this is an example, a 15-year-old female caught by the older sister making herself vomit in the bathroom after dinner. Parents were notified and are bringing her to see you at the office today. So you want to start the conversation with open-ended questions. For example, I'm concerned about your eating. Is it okay that we discuss your eating habits? Can you tell me how important is it for you to change your eating? Do you see it as a problem? There's a boatload of questions that we can start with, and just showing a lot of empathy so that our patient can trust us. Well, this concludes my short presentation. There is so much more that I can add, but this presentation is a brief version of what bulimia is. Thank you.